I welcome everyone from India and abroad to this International Cardiology CME. And without wasting time, I hope that we can start with the first talk. And I request Dr. Avdeep Singh to come forward to deliver his talk on TAVR for low coronaries or effaced sinuses, management strategy to protect coronaries, the BASILICA or CME, the case-based learning. And hello, first speaker.
Yes, Dr. Bang, I'll just start now. I'm going to start sharing my screen.
Yeah.
All right, good morning, everyone. So we'll talk about coronary obstruction in TAVR patients, what the management strategies are. So we'll start with a case. 77-year-old female comes in with symptomatic severe stenosis. And as you can tell, based on the gradient, it's like severe AS with a valve area of 0.5, and she's intermediate surgical risk. So her clinical characteristics, she was deemed an appropriate candidate for TAVR. And we decided that based on the sizing, 26 millimeter Edwards Sapien 3 valve will be the appropriate size for her with 16% oversizing. This is the rapid pacing run, aerogram, valve position looks good, and we deployed the valve, and it looked like the valve had good expansion, and you can see the leaflet being pushed into the sinuses. Right away, the patient becomes hypotensive, and this is the big fives that we always talk about: pericardial effusion, annular rupture, severe valve issues, arrhythmias, or coronary obstruction. Had an advantage of having a TEE in this case, and we quickly realized that there was severe new LV dysfunction that developed. And the aerogram rightfully shows that you no longer see flow in the left main. And this is a bad situation because we know that coronary obstruction has over 50% mortality. So over the next few minutes, we'll talk about how do we manage this. Either we panic and pray, or we can predict, plan, prevent, protect, and be prepared for a scenario like this. So the reason why coronary obstruction doesn't happen in every TAVR case is because the sinuses usually have an extra space that the valve leaflets get pushed into, so you still are able to have a normal coronary perfusion from the aorta into the coronaries. So retaining the flow into the coronary arteries. However, if you have deficient sinuses or sequestered sinuses, then you can have an issue that there is not enough room for the valve leaflets, and the valve leaflets can impinge onto the coronary arteries. And in a native valve, when the valve expands, if the coronaries are low and the sinuses are small, then you can have the valve leaflet that can move right in front of the ostia of the coronary arteries, leading to obstruction. And in a surgical valve, the issues are somewhat different. That the surgical valve leaflets, when they are pinned up, they become more like a tube. And in a normal scenario, when your sinuses have adequate sizing and the sinotubular junction is adequate size and adequate height, your blood can still flow from through the outflow of the valve up above the tube graft that gets created into the coronary arteries. However, if your sinuses are small and the sinotubular junction is low with a narrow diameter, then the valve leaflets from the surgical valve, they essentially close off any flow that can go into the coronary arteries. And we know from the experience that this is more so prevalent in patients who have a previous surgical valve which externally mounted leaflets, because that gets pinned into the sinuses adjacent to where the ostia is. There have been several observational publications that came out, and this is what we know so far. That coronary obstruction happens more so in females, happens more so in the obstruction happens more so over the left main artery as opposed to the right coronary artery, and patients who have small sinus of Valsalva, low coronary height, and more frequently in patients getting valve-in-valve procedures. So small sinuses, low coronary heights, bulky leaflets, and valve-in-valve with externally mounted leaflets. These are the big red flags when you when you're doing a TAVR and you want to predict whether there's a risk of coronary obstruction. Now, various predictive models have been created, and this is one of the things that we do, that you try to do a virtual transcatheter valve implant based on the CT findings, and you create a model and to see what the surgical valve leaflets would look like. And if you find any of these scenarios that the coronary heights are less than 10 millimeters, the sinus width is less than 30 millimeters, and the VTC, which is a virtual valve to the coronary distance, which is measured right here, or you can look over there, which is like there is no distance at all because the valve leaflets are coming over. The VTC less than 4, they are predictors for high risk for coronary obstruction. So how are we going to, now that we know what are the predictors, how are we going to prevent this? This is what's been done most commonly, or was being done most commonly, is the chimney technique. So we'll start with a case, 81-year-old female. She had a prior Medtronic core valve, 23 millimeter valve. She comes in with mixed valve pathology, that she has severe AS and aortic regurgitation at the same time, very symptomatic with a high surgical risk. So as we normally do, we discussed all the options and we decided that we're going to try to do, sorry, let me just go back. So we're going to try to do a TAVR in a TAVR. And based on the sizing chart, the 23 millimeter SAPIEN 3 valve was deemed to be the appropriate choice of the valve for this case. And we got all the imaging done. Unfortunately, she did not have any femoral access. So we decided that we will have to go through a transapical approach. And because of the coronary heights were low, we decided that we would have to protect the coronary arteries in this case. And we adopted the chimney technique. The technique is relatively straightforward. You have a guiding catheter, you wire the coronary arteries, you have a stent parked into the coronary artery, usually the LAD, and then you position your valve. And depending on how the scenario is, that if you think that the valve is going to definitely obstruct the coronary arteries, you may deploy the stent preemptively, or you can have a stent parked in the coronary artery, deploy your stent, deploy your valve, pull the stent back, and then you can deal with the coronary arteries later on. And if the valve is obstructive, then you can just pull the stent back and deploy it. So in this case, the coronary arteries do not have any significant stenosis, but based on the height, it was deemed that there is very high risk that the coronaries are going to get obstructed. So we preemptively wired both the left main and the RCA, and we deployed 3.5 millimeter and a 4.0 millimeter stents through using the snorkeling technique. Essentially, the technique is the following: that you have a stent in the left main, and you have a significant amount of stent hanging into the aorta to keep the valve leaflets from impinging onto the osteo of the coronary arteries. And that's what we did in this case. It was a transapical approach because there was no alternative access available. So after we did that, we left the balloons parked into the stent. In case the stent gets deformed, then we have the ability to redilate the stent with the same balloon. We went from the transapical approach, did the rapid pacing run, and deployed the valve. And this went without any issues. However, we had a small issue later on that there was bleeding at the apex where the surgeon had ligated, they closed off the puncture site. And they had to put an extra suture in the apex. And as you can tell, the coronaries are open, left main is open, right coronary is patent. However, the distal part of the apical LAD has poor flow where the surgical sutures went in at the apical site. But overall, this patient did well and had a small peri-procedural infarct related to the loss of flow to the apex. But otherwise, the patient did fine. So what are the clinical findings for patients who get chimney technique procedure? The main concern that we have is that this is a very relatively straightforward procedure to do, but the stent, which is going very in close proximity to the valve, the surgical or the TAVR valve, can easily get deformed. So there is always a concern that these patients can get thrombosis, and these patients can get stroke, and they may have poor outcomes in the long term only because The stent is getting deformed by the prosthesis. And what we do know is that there's a concern that these patients may do poorly over long term. The stents can re-stenose, so it can be very difficult to re-engage a stent that is hanging halfway into the aorta. It's going to be impossible to find the central lumen of that stent. What is the risk of ostial stent thrombosis? That is obviously high because the stent is deformed. And there might be another issue that there might be slow flow created in the neosinuses that are treated. What do we do with lifelong DAPT if this patient has surgical risk? And the outcomes, we don't know about the long-term outcomes, if they're going to be durable and consistent for all patients. And there's always a risk that there's a delayed coronary obstruction that may develop because the stent deformation may lead to high risk of restenosis. So we have to come up with an alternative strategy. So that's what we'll discuss with the next case. This is a 76-year-old female who came to our institution in the health system with bioprosthetic aortic valve that was done in 2012 with severe degeneration of the valve leading to aortic stenosis physiology. And the coronaries were, we had a coronary angiogram done. There were no obstructive CAD, but the patient was at high surgical risk. And we decided that we should have to address this percutaneously using a transcatheter approach. So the most important thing to know about these patients is to find out what the surgical valve implant was done in the beginning, because you want to size your new TAVR valve based on what the surgical valve sizing is in the beginning. And based on the characteristics, this patient had a Magna Ease valve, and we used the valve-in-valve app, and we came up with a 23 millimeter valve, which will core valve, which will be the adequate, appropriate size valve for this patient. Underwent the regular routine testing that we do for all patients, and her coronary heights are really low. She has left main, which is 8.8, and the right coronary is 7.7. So she's at very high risk for coronary obstruction. So this is a typical patient, small sinuses, low coronary heights, and this is a valve-in-valve. So you have to be prepared. And just going in, putting in a transcatheter valve, we know that we're going to run into a problem. So that's where we applied the BASILICA. So BASILICA essentially is described as bioprosthetic or native valve scallop intentional laceration to prevent iatrogenic coronary obstruction. So the tube graft that may get created because of putting a TAVR valve inside the surgical valve that can obstruct the coronary arteries, what we're trying to do is that we're trying to lacerate that valve leaflet so that when the valve leaflets get pinned into the sinuses, you create a gap that in front of the coronary arteries so that the coronary flow can be preserved. Now, if the surgeon had to do it when they open up the patient, they can easily take a scalpel and just make a slit. But obviously in the cath lab, this takes a lot more work and planning to do this. This is an animation of how the procedure is done. You put in a catheter into the sinuses. You put a second catheter into the LVOT, use a snare, wire across the leaflet, and you snare it out. And once the wire is externalized, then you electrify the wire and you slit it. And essentially you created a gap in front of the coronary arteries, and you have preservation of flow to the coronary arteries because of the gap that got created. Relatively straightforward procedure in the animation. Requires a lot more planning though. So based on all the imaging that we got for this patient, this was our case planning. She had a 21 millimeter Magna valve. There was no indication to pre-dilate because we felt confident we'll be able to dilate this valve properly. We decided that 23 millimeter Evolute Pro Plus will be the right size valve for this patient. Femoral approach was adequate. We decided to do it under general anesthesia, and there was no embolic protection that was going to be used for this case. And we put the TVP in the neck only because that we were worried that there might be high risk of heart block, that we may need the pacing for a prolonged period of time. And we routinely do TEE guidance for all these high-risk patients with the general anesthesia, only because you want the best imaging available to you. So use a CT guidance to guide us to what views to use. And the first thing first, that we put in a catheter into the left ventricle and use a V18 wire as an anchor and put in a 25 millimeter snare, gooseneck snare in the LVOT. The second step was to bring in a catheter, and these are dedicated catheters that are being designed for Basilica, which is essentially an AL iteration with catheter tip pointing down, and pointed the catheter at the base of the leaflet and use the TE and our prior CT imaging to make sure that this was an appropriate size, appropriate site for the engagement. And this was where the left main was coming off from. So the next step was that, okay, so these are the catheters that we're using. These are dedicated catheters, and these can be obtained from the Medtronic vendors, and I think there are some more companies coming up with dedicated catheters to help engage the cusp. So the next step is, after you have the gooseneck snare, you use an Asahi Estaro 20-gram tip wire, and back end of the wire you electrify and you perforate or traverse the valve leaflet, and you have a gooseneck snare, 25mm snare, which is parked in the LVOT. So more than likely, your wire, when it goes in, it will go through the central part of your snare. And you repeat the same thing on the right cusp. You have a snare, and then once you snare it, have the wire going through the snare, you externalize the wire. And this is what we talk about is the flying V, that the wire that is externalized, you have a kink in the wire so that you create a very, very focal area of contact between the wire and the leaflets. And you electrify the externalized part of the Asahi Estaro wire and then pull gently. It doesn't require much force once you put the electrocautery on it. You lacerate the left leaflet. We had a pigtail part before we lacerated the right leaflet, only because if there is any hemodynamic compromise, you have access to the valve and you can quickly deploy your TAVR valve, and then we lacerated the right leaflet. Now, the basic concept of why the flying V and electrocautery is important, this is important to understand. This is more physics than medicine. You're trying to create this flying V. The way it's done in the outside the body, you have the Asahi Estaro wire, and you take a scalpel and you denude the wire insulation. Then you kink the wire, make a giant, make a flying V. I'm sorry, the sound is playing on this. Create a flying V outside the body, and this is important. There's an insulation microcatheter on the proximal part, and you want to have that loaded on the wire because you don't want any loss of electric current in the catheter when the catheter is in where the wire may come in contact with the bloodstream or the saline. And if you look at the physics model, this is how it's going to look like. That you have the flying V, you have the wire that you scraped off the insulation so that you can have electric current focused in that area. And then you want to inject dextrose that will prevent loss of current on the other side where now the wire may be coming in contact with the blood. So you're getting rid of as much blood and as much saline as you can. So you have you're focusing your current on the inner part of the flying V. This is important to understand, otherwise you can be tugging on this really hard, and that can cause inadvertent injury to other structures. So after that was done, we put in a core valve. It was slide under expansion of the valve. We post-dilated it, and this is how the final result looks like. And you can clearly tell the valve leaflets would have clearly impinged on the left main artery and the right coronary artery, but after doing the Basilica on both sides, you have normal coronary flow in the left main and also in the right coronary artery. So just to recap on the steps involved. So you get your access in the LVOT, you put the snare there, and then you're going to traverse the leaflet using Asahi 20-gram tip wire. You put in and then the wire is snared, externalized. You create a flying V, deliver the flying V into the body, and then electrify it and lacerate the valve leaflet, and then deploy your TAVR valve. The outcomes for this procedure, as it's been described, has been done in a couple hundred patients. In our health system, we've done, I think, 3 cases so far. This is what we know from the outcomes from the group in Washington, that the coronary obstruction happened in 0% of the cases in which Basilica was performed. One concern always happens is that once you lacerate the valve leaflets, could you cause acute hemodynamic compromise because of acute AI, and the patient may not tolerate very well, but there was no significant increase in the hypertension for these patients. In hospital mortality was relatively low considering how sick these patients can be. However, this was the most concerning thing. Is there a higher risk of stroke in these patients? Numerically, it's like 2 out of 30 patients, but we don't know whether when applied to a broader group of patients, whether that's true or not. But it seems to work. There was 0 coronary obstruction. Now, this same concept can also be applied to patients who have physiologically bicuspid valve because of the fusion of the leaflets, like type 1 valves, that you can lacerate the native leaflets and create new laceration through there and essentially making a bicuspid into a tricuspid valve. Last but not the least, the delayed coronary obstruction has also been described. I have never seen a case for delayed coronary obstruction, but the definitions are that it can happen early, that 0 to 7 days. And that usually happens because there was like other anatomical features that we could have predicted this, and more so in valve and valve. Related to, because the valve is still expanding, could be dissection or hematoma, or it could be late because of the thrombus, fibrosis, or annulus formation on the valve struts, and that is obstructing your coronary arteries. So take home message, I think pre-case planning and imaging is absolutely important so that you can have all the information that you can use to predict what's going to happen. You need to have access to all the PCI equipment in the TAVR room. Sometimes we don't have it, we're doing it in the OR. In high-risk cases, preventative strategies are the way to go, because the paper that came out from Sierra Sinai from Dr. Rajmakar, that clearly shows that the patients who did not have pre-procedural protection, those patients did worse. Getting out these patients once they obstruct is not associated with similar good outcomes, and should be done with TE and general guidance and consider repositionable valve system. And if there's ever a doubt, we should always consider whether repeat surgical procedure may be the better option for these patients. And we've been through like tough times recently in New York, and we could not have done this from support from all the people around us and distant like people from India or other places in the country. So thank you, everyone.
Hello, Dave. Yeah, brilliant presentation with great examples of all the cases. And you have also demonstrated the technique in detail in live and also in the form of animation. And that was really a brilliant presentation. I could understand very clearly when the chimney is to be considered and when to consider basilica, and how technique is difficult and in what circumstances you can do it. I think it's a brilliant presentation. I appreciate that. Thank you very much. Question answers will be at the end. So so I can invite the next. Thank you very much. I can invite the next speaker. Next speaker is Dr. Ramesh Dagupeti, and he will enlighten us on current status of TAVR in aortic regurgitation, which is also a very interesting topic. And earlier also, the Amni's topic also was very interesting. I don't think we do basilica in India. So far, as far as my information is concerned, basilica is not done, although chimney is done a couple of times or maybe more times. Thank you very much. Ramesh?
Yes, thank you very much, Dr. Bang. Great pleasure being here. And I thank all our participants who are there in the evening on a weekend. And, we're going to talk about TAVR for aortic regurgitation, the current status. These are my disclosures. So as aortic stenosis, even aortic regurgitation treatment is very important because the survival without any aortic valve replacement, mortality is about 75%. And so in severe patients, but otherwise in all comers, I think the mortality is about 25 to 30%. And this is from STS database, and with aortic valve replacement, the mortality comes down to less than 5%. In a European heart survey, about 10.4% of the patients who have native valve disease have isolated aortic regurgitation. And I'm sure that in India, because of rheumatic heart disease, this is much higher than what it is in other parts of the world. And but here, what we see as aortic regurgitation is mostly probably people with bicuspid aortic stenosis or who have associated aortic root dilatation. And obviously, surgical aortic valve replacement is the gold standard for aortic regurgitation. And in people who have non-calcified aortic regurgitation by itself is a relative contraindication for TAVI, and it is off-label indication for all the valves that are FDA approved or available across the for commercial use across the world right now. So we do use sometimes TAVI for bicuspid who have a combined stenosis with regurgitation, and but it's relatively contraindicated if they don't have any calcification at all in the valve or leaflets. And that said, even if you think about all aortic regurgitation, this is not going to be something like a mainstay therapy such as aortic stenosis with the TAVR, because there are so many other diseases that are associated with the AI, such as congenital malformations, and maybe AI is due to endocarditis, or they have associated dissection and aortic root dilatations and Marfan's. So only 50% of all the patients that have severe AI will be eligible for even TAVR. And as we know that, but people who are eligible for some sort of therapy such as SAVR, surgical aortic valve replacement, about really in 7.8% or so of patients do not get any treatment just because of their age and frailty, and that has been studied by STS and has been published as well. So if you think about what are the problems with that in the challenges in treatment of non-calcified aortic regurgitation, you can look at it. Number one is they have large annuli probably. And even recently I had a patient who had a large annulus, and we actually thought maybe surgery is the best therapy, or we would leave it alone. And we tried S3, but it didn't stay in position, and it actually embolized into the ventricle. But the patient was stable enough that we had to bail him out with the surgery. And the most problem is insufficient anchoring, and due to all these factors, there will be dislocation and embolization. And sometimes you might still have a residual AR, and try to treat it with another device. And having a concomitant aortic dilatation, sometimes if you place a core valve type of valve in the aorta, in the aortic valve, you might actually cause more problems in the future if they have to do any surgery. It's very difficult, and our surgeons really hate it. And so there's always increased need for permanent pacemaker that we are always evaluating, whether for AS or AR. And despite all these limitations, as you see that there is great interest in TAVR for aortic regurgitation by the number of publications that have come across in the recent 5 to 10 years. And so people are really trying to push the envelope and try to see how we can treat the percutaneously isolated aortic regurgitation. So when you think about anchoring mechanisms, where can we anchor? Can we anchor it in the aortic root, or it can be anchored in the leaflets or the annulus alone? So initially, core valve was thought, this good device. It has this type of shape of the funnel, and so it might be able to anchor to the root, and it may not be embolized. And then the symmetis also is there on the first one you see, and then the core valve. Both of them can be anchored at the root as well as the annulus. And the annulus alone, that's what we do now most of the time, is some sort of sapien or direct flow, which actually I think it is probably has a good chance of coming back. And also the lotus edge valves that are repositionable completely. And the newer valves are the Yana valve or the J valve, and these are the ones that actually look at the leaflets and the annulus, and I think this is probably where the future is going to be. So anchoring and annulus and aorta with, as we said, initial excitement about core valve was done in about more than 70 patients in early experience. And the fixation relies completely on radial expansion and maybe post-dilatation and oversizing this valve. And the second valve is required in about nearly 20% of the patients. Nearly more than 20% of the patients are still left with the more than mild aortic regurgitation. And new pacemakers are really up to 5 to 15% of the patients were seen. And even though I think Evolute offers repositioning, that actually has not been the greatest device for pure aortic regurgitation. Then the Cemetis Accurate, which is now part of Boston, looked at a case series of 8 patients, and Accurate transfemoral system was also used in this aortic regurgitation patients. And the stabilization of the arches and upper crown aid alignment and positioning. So there are arches, and these are the crowns which are there, definitely control the valve from embolizing. And the fixation is at the waist, like within the annulus, no significant complications, and the aortic regurgitation is a trace at all, if at all. And in early ACC and STS TVT registry experience showed that Evolute R had a higher chance of device migration in aortic insufficiency as compared to aortic stenosis, higher chances of embolization either into LV or into the aorta, and repeat second valve intervention is much higher. And obviously all-cause mortality was 15% in aortic insufficiency as compared to 3% in aortic stenosis. So that, I think, by itself, it says that it is really not an acceptable type of device that can be used in these type of patients. Here is by Hendrik Tiede from Germany. He showed at CRT this patient where he treated with, for a pure aortic regurgitation, he treated with Cemetis Accurate transfemoral system, and EF was 55% and Annulus was 22%. So he really did a good job in reducing the AI with the Cemetis Accurate system. And it's not as easy as it appears to deploy that valve, and it has sometimes you have to make sure that the crown and the upper crowns are really catching onto the valve very carefully. This is a registry that I came across from Korea and Cedars, and looking at early generation versus a new generation. As you can see, core valve was used in about 92% of the patients in early generation, as compared to Yana valve in the 30% and direct flow in 16% of the patients, and all the other devices are less than that. And obviously learning time and so procedure time is longer in these the new generation devices, but this is a nice registry that retrospective registry is looking at about nearly 300 patients or so. And what it showed is that the need for second valve implantation is much lower, 50% lower compared to early generation devices, and aortic regurgitation is much less in people with the new generation devices, and pacemaker rates are similar. And the device success is much better with the new generation devices as well. And the 30-day mortality is significantly lower by about an absolute risk reduction of about 4% between the two devices. So if you look at it, aortic regurgitation, people who have more than moderate aortic regurgitation in the red line, the mortality is nearing about 50%. But whereas in people who have less than mild AI, after the procedure, the mortality is still 21%. So I don't know whether this is acceptable, and I think this is where we try to debate. But don't forget that these are all early on and experiences, and we have to make sure that there's a better randomized controlled trial. So you can see among the different types of valves, which valve is better. Even though we try to think that Evolute R is slightly better than core valve, but still. Obviously, the one in the magenta and the Yana valve or the direct flow appear to be much better than all the others, including S3. So the need for second valve implantation is about 9.4% with the Yana valve, and the post-procedural aortic regurgitation is 1.6%. New permanent pacemakers are about 15.8%, and the device success is about 82% with the Yana valve. And I think this is what is more important, and S3 is coming close to it, I think, but still there's a lot more I mean, the pacemaker needs are not much lower with S3 as well. It is 18%. And definitely the post-procedural AI in the small registry is lower, about no regurgitation with the S3 valve. So that said, do we think we can fix all AI with just one type of valve like S3? I don't think so. So I think the more reiterations are going on with the Yana valve, and initially it started off with the transapical and was CE marked for treatment of aortic regurgitation in 2013. They had done a case series of 31 patients, and there's a feeler-guided self-positioning. Anatomical orientation is very important, and mild AR is seen in about 10% of the patients, and new pacemaker rates are less than 10%. But because it's a transapical system, nobody likes it, and I think it was removed off market in 2016. Now the transfemoral system is coming in, and it is CE marked for a study. And I'll show you these pictures where you can actually see the positioning and deployment in step one. Once you cross with a safari or a wire in the left ventricle, you advance the system, and there are these cusps which go into the sinuses, and actually, or the paddles which go into the sinuses, and they can position the valve much better. So the first thing is actually you rotate the deflector, move the catheter off the aortic wall, and gain axial alignment. And after that, you can still rotate so that you can see one in the second picture, you can see one paddle here, which is a soft pad, and it is going into the sinuses, and the other one is going to the other sinus. And that way, now you are not going to have any embolization of the valve, and you're going to fixate it, and then you advance the controller to position and align the valve. So since that is done, you're know where exactly you are, and then you can rotate this deployer to deploy and release the valve completely, and it is easily done. And as you can see in the pictures here, these are the markers which are there. Sorry, the markers which are there in which are going to the sinuses, and you can see and by the position, the field that you have, and also by aortogram that you're in the right position. And then you rotate and deploy the valve, after which it is completely deployed. And till that, the third picture, you can retrieve it back. But after that, obviously, you're completely going to let it go. And so it is sort of a valve-in-valve type of frame system that I think that it prevents embolization, and it makes it more stable, and it does not allow, let it go into the left ventricle at all. And the root angiogram shows no leak at all. So Yana valve global clinical program, which was presented by Steve Balders from Germany in Cologne at EuroPCR last year. And there's almost nearly now, I think the number of centers are increasing, about 40 centers or so. And the US and Europe both have combined, and this is a prospective multi-center arm study. In the US, actually, Raj has the highest, Mucker has highest experience from Cedars, and Steve Balders from Germany has the highest experience in Europe as well. And even though this is an old slide that shows 43 patients, I think they've passed beyond 70 patients now, and enrolled at nearly 20 centers. And what it showed is that intra-procedural mortality is 0. That's the most important part. And correct positioning of the valve is in the upper 90%. And the device success is at 1 month is 91%, which I think is one of the highest ones so far we have seen. And the all-cause mortality at WAC2 early safety measures are all very good. Less than 14% of complications such as major vascular or device-related complications, and stroke and mortality all included was seen in 6 patients, that is less than 14%. The next one is actually a dedicated valve for aortic regurgitation. Is a J valve from a JC Med company, and it is started off with the transapical axis, and obviously all of them try first do transapical and then are coming into transfemoral. and it has a U-shaped graspers, and as you can see that it is very good graspers on either side of this picture, the frame and soft metal frame, and they fixate the cusps and embracing the aortic annulus, and it has been evaluated in about 43 patients of aortic regurgitation itself, and the technical success similar to Yana valve is seen in 92% of the patients, and pacemaker rates are much lower, about 5%. And trace to mild AR is seen in 100% of the patients and nothing more than that. 1 year mortality was about 5%, and this has been published in 2018 in a Journal of Cardiology. So this is how, this is obviously a video that actually it shows that how this could be done. You do a transapical, go in, and so you can rotate from the end, and that releases that frame which you can pull down. And when you pull down this, there are crowns that go into the sinuses and they stabilize it. And so it's somewhat similar to Jenner valve. And so then you rotate the proximal rotator, and that actually deploys the valve, and you can come out easily. And it is very successful, shown to be very successful. So this is a transapical system, and as you can see here, these are the nice soft cusps, crowns that go into the sinuses. And this has also, even though this is a pictogram, that this is how it is seen, that those things come down, and it is loaded onto the sinuses, and it is stabilizes. And then you can actually position the valve with, according to the clasper, and release the valve, which is going to stay in position again because of that crown that is stuck in the sinuses. So, you know, again, the severe AR that was treated with J valve was very successful and has been really great in trying to make a roadway into treating patients who are too high risk for surgery and who cannot have a medical therapy alone because of their symptoms. They have been shown to reduce their New York Heart Association from class 3 and 4 to about 70% of them were in class 2, and 30% of them were in class 1 with the treatment of the new valves, which are Yana valve and the J valve. And so the advantages of these two valves is the insufficiency patients are indicated not only for stenosis, and auto position and the visual is secondary, and it is going to reduce the contrast usage, and very easy to operate, and no need for extensive experience, and very easy to train as well. And in conclusion, the take-home message is remaining challenges for TAVR and AR. Obviously, the lack of approved devices, and I have to tell you that I have had no experience with all these the new valves. We are trying to get into the study with the Yana valve, and but I don't have any experience with the J valve or Yana valve. Transfemoral J valve has already come in, and it was the first procedure was done at Christ Hospital in Ohio, and so obviously whatever transapical now, soon they will be all done transfemorally. I think the future is going to be really great, but the current devices carry an elevated risk for procedural failure. There is a lack of retrievability in most of these valves, and active positioning and fixation. These are the, without dilating the aortic canal, become a problem. And the sizes, you know, it's still, we still have a problem with the all the sizes, and appropriate size is important. And, you know, when we choose the wrong size in the large annuli, it is going to be a huge problem. And we are pushing the envelope at times, and I'm going to treat on next Tuesday annulus of 750 with the 29 valve, which is only actually meant for up to 640 or 680 square millimeters of annular area. And so, I mean, we do sometimes push the envelope, and we are going to gain more experience with these type of devices. And long-term results and durability, especially for progressive aortic dilatation, is going to be something of interest, and whether they can be in the future, if they need surgery, younger patients who have severe AI, if we treat them, and
screen set.
future surgeries might be an issue if there is aortic root dilatation, and we have to watch on that.
I should be seeing.
So in short, I think a Jenna valve and J valve are possible upcoming solutions, and we have to keep a close eye on these two devices. With that, I end, and I'll take answers at the end of the session. Thank you very much, Dr. Bang, and great pleasure being here.
Great presentation. Excellent. Excellently, you demonstrated the various valves which are available in the market, and I think future looks to be very positive, particularly with the newer J valve and the Jenna valve, and then there is some other also VRC work valves. These are 3-4 valves which I have also read. You know, when the rheumatic fever, can we deploy these valves? This was one of the questions which was asked to answer. And there is some study done in the South Africa where they have deployed in the rheumatic fever the TAVR, and the results are not that bad. But obviously it needs some anatomic research by which it can anchor the valve. The main problem is the dislodging the valve from the valve position. But these valves that you have shown very clearly demonstrated with the animation that it's very clearly seen to be anchoring at the valve. And unfortunately in India, that we see a less number of degenerative disease, perhaps because of our census has declared that only 7.5% of the population is above the age of 60 years. And above the age of 75 is only 2%. So the number of people who are there, but looking at the population size, even 2% becomes a large number. I agree with that. But many go for the SAVR because of the cost, and less go for the TAVR.
Yes.
Full screen. And question answers we will cover at the end. And I believe everyone would appreciate that there is something which is even considered, even for, TAVR is considered even for the aortic regurgitation, and it will be, it will certainly have a positive impact over a period of years, next few years maybe. May I call upon the next speaker, Dr. Rajiv Johar. You know, recently COVID has created a huge damage in the whole world, and Dr. Rajiv Johar has the greatest experience in handling COVID patient, and he will tell his experience about cardiac involvement in the valve. He's from New York, a Northwell Health System, and let's hear him, what he has to say. Rajiv?
Vijay, thank you very much. Terrific webinar so far. Avneet and Ramesh did a great job, a tough act to follow. You know, New York is now the epicenter of the US pandemic. And we have seen a large majority of the patients with COVID in the US at our health system. And it's been a challenge, and you know, this great picture is, you know, the community has really gotten involved and supported us, and really, you know, it's been a wonderful experience as well as a challenging experience. You know, the pandemics are there, and they're there to stay. From 1720, it's amazing, 1720, 1820, 1920-ish, and now the 2020 pandemic. So I will not be there 2120, but I suspect that's the next pandemic. But, you know, we've learned from each of our pandemics, and social distancing is a big issue that we're having a hard time with in the US as states start to open up. You know, from a cardiac perspective, we have seen that the abnormal is now the normal. You know, we've seen patients who present with classic ST elevation. This is a 51-year-old gentleman who presented with ST elevations early in the COVID era, and we took him straight to the cath lab. He was intubated, and we took him to the cath lab, and he had normal coronaries. And so our concern was that he had focal myocarditis, myopericarditis, and we've seen several of these in the last few months with essentially normal coronary arteries. EKG is suggestive of a myocardial infarction because they're focal and not diffuse like a pericarditis picture. His ejection fraction initially was normal, and so after the case, as we're planning on to see what we're going to do with him, he gets worse in about 15 or 20 minutes. And we do a transthoracic echo, and his EF has gotten worse, and he's got a large pericardial effusion that required tapping that we sent off for serologies. And, you know, he got admitted to the hospital, and we watched him essentially just die. I mean, there were no options for this gentleman. We had him initially on 1 pressor, then to 3 pressors, then 4 pressors. And without any support, he passed away. We thought about ECMO in this gentleman, but our experience with ECMO has been very weak and very poor in these patients. And basically, he developed multi-organ failure and died within 36 hours. We're seeing a large number of patients who don't fit the norm. They're younger. You know, one of my colleagues had a 33-year-old gentleman who had a acute left-sided stroke and is now doing extremely poorly, otherwise healthy. We have seen healthcare workers who run marathons get COVID and do poorly. I have 2 of my very good friends who are doctors, both on ECMO, one with a left hand thrombosis that required surgery and a fasciotomy. Another one still on ECMO now, 2 weeks later on trach. So, you know, the COVID does not discriminate against with color, with race, with political affiliations. It hits everybody. It hits everyone very, very hard. You know, one thing we've noticed in New York, and this has been borne out in studies from Spain and Italy and China, is where have all the heart attacks gone? You know, we've seen a dramatic decrease in true heart attack patients in the COVID era. They have they're either staying home, or the fear of them coming to the ED and the emergency rooms has led them to stay home. So I'm suspecting we're going to see a large number of patients with ischemic cardiomyopathy. Our preliminary evaluation of our data, you know, we've done over 11,600, taken care of 11,600 COVID patients, and our initial evaluation is that the average time of symptoms to presentation to the ED for these patients is running about 2.7 days with chest pain, when last year at the same time in the same cohort of patients it was running about 2 to 3 hours. So clearly there's a fear of patients coming to the ED. And I can anecdotally, I see that in my own friends, you know, who call me at night with chest pain, and then I tell them to go to the ED and they refuse. They will not go. They say, we'll see how I do tonight. And then they decide the next day. Everyone has become an expert now. If you go online, you go on Facebook, you go on YouTube, all the webinars, everyone seems to be an expert on what has happened to heart disease. I can tell you that there's very few experts, maybe on this panel and some of the national organizations, but unfortunately there's a lot of conspiracy theories out there that I sort of, I try to respond to now, but it's getting to be very, very difficult. But people are finding every reason to justify what is happening so they get their few seconds of fame. You know, this is the normal became the unexpected, you know. This is a gentleman with COVID who developed a large pulmonary embolism, young guy, and this is what was moved with the Annulus procedure from his lungs. So clearly, what we have seen in these patients is a large hypercoagulable state, but not in the heart, more in the periphery, in the carotids, and leading to stroke, and in the arms and the legs. We've had several patients who have actually lost limbs due to this hypercoagulable state. we've seen a lot of patients with pulmonary embolism, young, old, middle-aged, all of them. Like I told you, my friend who's a physician, she's in her early 50s, had a thrombosis to her left arm. That became very common. And so what happened to these patients? You know, we got some data which we're about to publish from the New York City Fire Department. And if you see the number of patients who who were called, who 911 or our emergency lines were called, the peak was on the 5th of April, where there were about 280 patients who died at home. EMS was called, and they came home and they died. This is comparing that to the year before, which runs normally about up to 30 a day. We hit 280 in one day, and it's it fits the bell-shaped curve. And our health system peaked around April the 7th, and it has now gone down. We initially started with 3,400 COVID patients at the peak, and today, this morning, we were down to 1,200 COVID patients. And with the increase in volume of the COVID patients, and them taking over basically our whole hospital, one of our hospitals, which normally houses up to 600 patients, it peaked at 910 patients in the middle of April, in early April. So our cardiac catheterization volume dropped by 83%, our EP procedures dropped by 82%, and the rest of our procedures dramatically dropped, including inpatient and outpatient cardiac visits. One thing that has really exploded is telemedicine visits. Our health system is now doing about 3,500 to 4,000 telemedicine visits per week, which is very dramatic. So this became our new norm. You know, this is our cath lab recovery space, which became a COVID unit. This is our Rust auditorium. This is where the speaker stands and speaks out over here. This became a COVID unit. This is our short stay unit where we keep our post-angioplasty, post-EP patients, and they became a COVID unit. This was sealed off to prevent the staff from getting exposed. We even got a mobile hospital, and this is our mobile hospital. We took one of our cath labs and made it into a recovery space for the patients we did do procedures on. And this was our mobile hospital that is still there, and we suspect will be there now for the near future as we get probably a second wave of patients. If there's any silver lining, is that we created a lot of partnerships, interdepartmental with the Department of Medicine, as we redeployed our physicians. We redeployed 72 physicians, of which about a half were fellows, cardiology fellows, to ICUs, to inpatient hospital areas. We developed partnerships around the health system. You know, we created a WhatsApp group with about 170 interventional cardiologists from the tri-state area, where we talk and discuss policies, procedures, cases. The case that I presented earlier, I streamed it live to our group, and they were giving me advice on how to proceed with that procedure. So the COVID era, what has changed? Well, you know, the causes of ST elevations, the classic ST elevation, myocardial infarction, are not as common. We're seeing a lot more focal, I would presume myocarditis, but we're not sure if they're microthrombi or it's myocarditis. We are really being very aggressive with echo imaging prior to intervention in these patients, especially if they have normal LV function on an echo and with ST changes. We do not take them to the cath lab because the prognosis is extremely poor in these patients. The guidelines of door to balloon time have gone away, where our average door to balloon time normally was about 67 minutes in our health system, is now running from time of presentation and EKG to a procedure in the few patients we have done is running well over 3 hours. There's data out there that suggests maybe thrombolysis may be better in these patients. I would argue that it's probably not the right choice in situations like the previous case, where you have a large pericardial effusion, a lot of normal coronary arteries in these patients. So I believe that knowledge is very important, and knowing what the coronary anatomy is very, very important, or just treating the patients medically. We had a couple of our staff get COVID. 2 got very sick, actually, requiring a 100% non-rebreather. Eventually, God willing, and they did well. But protection of the staff with proper PPEs it has been very, very important. Initially we had issues with N95 masks, but that's all gone away now as the number of patients have increased, the number of masks have increased. So what are some of the lessons we have learned so far that we can disseminate to the world? Well, you have to presume everyone is COVID positive. 80% of COVID patients are asymptomatic. And so, the person sitting next to you could be COVID, and your response to the COVID, to COVID may be different than his or her response. And so it's very important. And we've also seen that patients with cardiac risk factors like hypertension, obesity, lack of exercise, diabetes, and of course, heart failure and coronary artery disease do worse, and it portends a worse prognosis. Staying ahead of the curve is so important. Our first case in the U.S. was on January 21st, and we had a window of opportunity before we had the shutdown in March 16th that we did not do a good job in creating ventilators and creating a stockpile of N95 masks. PPE is life-saving. Dr. Miraj has always said that from the beginning, and I initially poo-pooed it initially, but he is completely correct. It is life-saving. We do it now on every one of our patients. We presume every patient has PPE. Innovation is key in this situation, as you can see with telehealth, e-health, which has really taken off, telelearning. Our fellows conferences are now done with Microsoft Teams. And we do routine lectures now across the country with Zoom, like we're doing now internationally. We have an ability to change the paradigm. We were sending very few of our patients home, but now same-day procedure and discharge is very common. I was fortunate enough to do 4 PCIs 2 days ago, which is a big deal now. Usually our lab does about 300 a year. I think we did 30 last month. So I did 4, and I sent all 4 home the same day. It has really given us an opportunity in terms of drug use and trials and research. We've created a consortium of 11,600 COVID patients that Dr. Singh and Dr. Miraj and I are mining to get some more data to publish. We've already published 3 papers in the last 3 weeks on this very topic. So what is our goal? Our goal is to reinstitute procedures, but overcome the fear of the patients by creating a COVID-free space. So like I showed you earlier, our cath lab recovery space and our short stay unit, which is near our cath lab, were ICUs. Well, now we've taken all those patients out, moved them to other areas, and created a COVID-free space to assuage the fear of the patients. But that will take time, and it's probably several months. We're seeing that when we call 15 patients to come in for a semi-elective procedure, 3 say yes. The safety is of paramount importance. Every patient who comes in our cath lab now gets a pre-procedure COVID test up to 48 hours prior to the procedure. PPEs are commonplace because we want to mitigate the second wave. We want to mitigate the next wave. We know that from the Spanish pandemic, although it was a different era, the second wave was much worse than the first wave. So our 4 Ps to elective re-engagement are preparation, the patient, the procedure, and the post-care. And that all revolves around a safety to the patient, routine staff testing, appropriate PPE space, and getting the patient out of the hospital with follow-up with telehealth. We have prioritized our cases, so we're not doing any urgent, semi-urgent, or non-urgent procedures, and we're only doing elective procedures that are higher risk, post-infarct angina, patients with very, very positive stress test, or obviously emergent type 1, or emergent STEMIs or type 1 non-STEMI patients. In the COVID era, we're not rushing to go to the cath lab. We've done 28 COVID positive patients in the last 3 months. Imaging, evaluating prior to activating the team. I'm not a big believer in thrombolytics unless we think it's a non-cardiac thrombosis. We assume every patient has COVID-19. And we can't really extrapolate the Chinese data to the United States because of the abundance of cath labs in our area. But we have a lot of hope. You know, this was yesterday. This is our cath lab recovery space that was given back to us yesterday on Friday. So, you know, there is hope. With intelligence and smart thinking, we can go forward. So I'm happy after the talks are done to answer questions. I thank you for your time.
Brilliant presentation. We have learned a lot from this, that how COVID can create a havoc in the human body and create a very difficult scenario to manage. In fact, cath lab work and number of STEMIs, everything has come down because of the fear of the COVID. But PPE, I think, is a blessing overall. And but the kind of cases that we are able to see here, that testing is a big challenge here in India. We are unable to get large number of patients tested, particularly with the PCR, and we don't have at the moment the antibody testing. Whereas differences in USA, Abbott has created a new test which is very quickly positive, and large numbers of tests are done there. So detection may be higher. But one difference that I have noticed, that the age, the demographic, the higher age patients are more in the above the age of 60, more in US as compared to the India. India has a lower age patient. Average age in India is 28 years only. And the only other problem in India is the density of population. The density of population in America per square kilometer is just 33 people. In India, it is 480 normally. But if you take a suburb, some of these slums like Dharavi, there the density is 2.57 lakh per square kilometer. It's very high. So it's very difficult to keep safe distance and manage everything. So it's a kind of a fire area, not hotspot. It's kind of become a fire spot in one particular area in Mumbai. That looks pretty challenging. We have learned a lot from your talk, how to look forward and how to gear up to, you know, resume back to work. And I'm sure this talk I will circulate everywhere and will help us a lot in understanding how to go back and, you know, resume to work, and also bring out a strategy for the second phase. That's a good thing. We will, I think, come back with this second talk from you on this when you are fully ready with the second phase. Nice talk, very brilliant talk. May have call on a next speaker. That is Dr. Raj Tayal. He will deliver his talk on AMI cardiogenic shock. We know that we are stuck in some time in a cath lab where we see a patient having a extensive anterior wall MI, but LED is patent, but patient is in a cardiogenic shock and not recovering despite the support, single support. So let's learn from Dr. Tayal, how do we manage these patients and save their lives. Dr. Tayal, please. Unmute. Dr. Tayal, unmute. We can't hear you. You need to unmute. Down below there is, you know, below the screen.
Yes. Can you hear me now?
Yeah, we can hear you.
Perfect. Yes. And are you able to see my screen?
Yeah, your slides we don't see, but we can hear you. You have to share the screen.
Okay, 1 second, I'm sorry.
Okay, we can see you now, and yeah,
Very good.
can you just increase your size from, make a.
Yes, just give me 1 second.
Yeah.
Perfect.
Yeah, good.
Thank you, Dr. Bang, and thank everyone and all the panelists for joining us. I'm sorry for being somewhat discombobulated. I was called in and in the hospital until 4 a.m. It's been a truly challenging time, even here in New Jersey, although not quite to the degree as New York was affected. All of our hospitals and systems have been overrun and have suffered similar challenges to what was described earlier with regards to COVID. Anyway, it's a pleasure to be here and discuss MCS among acute myocardial infarction and cardiogenic shock. We'll review some of the data and some of the devices and kind of some of the decision and clinical guidelines that help us select the best device for the patients at appropriate times. So over the course of time, the frequency of cardiogenic shock has remained relatively stable. If you look at the number of patients that are presenting across the United States and across time have remained stable. And in line with that, the mortality has also remained relatively flat over the last 2 decades. Although initially we did see some improvement with advancements in technology and interventions and the advent of door-to-balloon time, you can see the overall mortality still remains around 50% for patients presenting with cardiogenic shock. Now, the major causes of cardiogenic shock are well-defined and relatively well-known to most. Of course, acute myocardial infarction being the large or lion's share of the etiology of shock, with a couple of valvular heart disease and isolated RV shock contributing to that as well. Excuse me. So overall, the problem behind cardiogenic shock involves a hemodynamic problem that evolves into a hemometabolic problem. And until recently, we had kind of taken a more watch and wait kind of conservative approach. But what's kind of been teased out through time and with data is that time to intervention is equally important in shock as it is in acute myocardial infarction. So really preventing the progression of hemometabolic spiral has become the key focus. So rather than waiting, we try to intervene early and really prevent the spiral, if you will, of progressive myocardial dysfunction. So what we see initially is you see LV failure, which contributes to a decreased stroke volume, cardiac output declines. Then you have increases in LV wall stress, which relates to increased myocardial oxygen demand. And this further decreases coronary perfusion as the LV-EDP increases, and then subsequently results in renal hepatic congestion as well as biventricular dysfunction and further end organ compromise. So really there are a number of different equations and different ways of looking at things. A lot of us were initially mostly focused on mean arterial pressure. However, more recently, I think people should be looking at a lot of other parameters, such as lactate, creatinine, the end diastolic pressures, and how these things impact the rest of the organ systems in the body. So it's really looking at the overall picture and kind of putting it all together. Sorry, my slides are stuck. So in terms of choices for acute myocardial for MCS in shock, we are stuck, and these are the choices that we have at this day and age, usually comprised of intra-aortic balloon pumps, which have been available for the last several decades. We also now have Impella devices from 2.5 to CP. The PHP device has been studied initially, however, is not commercially available as yet as one of the other axial flow devices. And then there are all these centrifugal devices, such as Tandem Heart, which requires AV access as well as a transseptal puncture, and VA ECMO. So really, when you look at the choice of devices, this is an illustration of how intra-aortic balloon pumps function. There are several different iterations from 25 cc's all the way up to the Mega 50. If we ever use any form of intra-aortic balloon support, we often use Mega 50s as the only support, assuming that the patient's body habitus can tolerate it. However, what you're aiming to do here is augment end diastolic pressure, thereby increasing cardiac perfusion and decreasing the end diastolic pressure and oxygen demand on the system. So some of the pros of the use of intra-aortic balloon pump is it's a relatively well-known technology that's well established. It does, as I said, increase coronary perfusion. It slightly augments the cardiac output, but I think the most beneficial aspect of it is that it's relatively easy to use. It's relatively easy for the staff to manage, and the cost is relatively low. However, some of the problems with this device is that it requires intrinsic cardiac function. Dysrhythmias are not its friend and not an ally to its use, and it only allows for modest unloading of the heart. So as you can see from a hemodynamic perspective, what its effect on the heart is you will see it results in a mild decrease in the LV pressure and small increase in LV volume, resulting in an increase in cardiac output. However, when you put this in context, what's looked at and been well defined in the IABP shock trials is that if you look at the outcomes of patients presenting with shock in terms of mortality, again, we had talked about this being stable at around 50%. You look at patients that were treated with balloon pumps in the setting of acute myocardial infarct and cardiogenic shock, you can see that there was no statistical difference whatsoever in patients treated with balloon pump support versus undergoing percutaneous coronary intervention without. So when you compare data and outcomes of Impella versus IABP shock, what you can see is that the improvement in cardiac index is defined with the use of these transvalvular pumps. And you can see that the cardiac power index also statistically improved in patients receiving Impella support as compared to those using intra-aortic balloon pump support alone. So some of the hemodynamic principles behind continuous flow, again, it revolves in decreasing the end diastolic filling pressure and improving the oxygen available for the system. So the more dysfunctional the ventricle here, the more functional this device becomes, almost inversely. Now, comparing the hemodynamics here to VA ECMO, you can see that VA ECMO actually results in increased afterload as well as increased preload. So it is not an unloading device. However, it will result in increased aortic and left ventricular pressures. So again, when you kind of look at this, there are different indications and different means to doing this. A lot of the indications for VA and VV ECMO relate to oxygenation, and we've seen a fair increase in demand for that in the current COVID era. So as we had kind of looked through some of these different things, as you compare that to Impella hemodynamics, what you can see is this is an unloading state where you're decreasing the left ventricular pressure and you're also decreasing the amount of preload, thereby increasing the aortic pressure and allowing for AV uncoupling. Sorry. So overall, what you're seeing with the use of Impella in acute myocardial infarction is you're seeing improvements in cardiac index, improvements in mean arterial pressure, a decrease in SVR, as well as overall wedge pressures. And then as we continue to support the system, you can see that this also affects end organ systems, resulting in decreases in blood lactate level. It also improves renal function, as I'll show you shortly. Now, comparing the two rates of survival in patients treated pre versus post, I think one of the things that has been extrapolated from more of the recent data, including PROTECT 3, revolves to early use of MCS ahead of time as showing the largest signal for improvement in survival and mortality. Again, comparing this pre-PCI, Impella versus balloon and inotropes, you can see that there is an improvement in overall survival. And as I had stated, this relates to the organ perfusion, where you have a decreased incidence of acute kidney injury related to decreased perfusion as well as contrast nephropathy. So this is kind of a nice summary for looking at the appropriate device for the appropriate patient, kind of matching the patient to the presentation, and some of the benefits in terms of what IABP does versus ECMO versus tandem heart or Impella. And what you can see is that Impella is able to help not only with circulatory support, ventricular support, as well as coronary perfusion and decreasing hepatic congestion, as is a combination of these devices such as ECPella, which means a combination of ECMO and Impella. Tandem heart is something that we initially used quite often, however, have kind of decreased its use and moved more towards the use of the ECPella combination in lieu of that. So, in summary, it's important to really match shock with the presentation and the hemodynamic problem that's being presented with. And the key is timing of implantation and really understanding the hemodynamics to help you select the right device for the right patient. So I have a couple of cases I'll briefly go over. The first of which is a 70-year-old female. She was hypertensive, diabetic, long tobacco history. So she presented in respiratory distress with a respiratory rate in the 30s. Was started on CPAP and then escalated to BiPAP in the ED. You can see her pH was 7.3, her lactate was 3.2. Pro-BNP level was in the 3,000 range, a mild elevation of troponins. Her EKG showed an incomplete left bundle branch block. Blood pressure was borderline in the hundreds. Her heart rate was also in the 100 to 120 range. A quick point of care echocardiogram was done by one of the fellows, showed that the EF was around 30%. The patient also had a moderate degree of valvular heart disease and elevated right-sided pressures. Here are some of the baseline images. You can see the EF is reduced, and don't judge the use of the end-hole catheter there. It was a hand pressure injection. She's got a functional chronic total occlusion of the right coronary artery. Her hemodynamics are highlighted above with a right atrial pressure of 14. Her mean pulmonary artery pressure, you can see, is 41. Her cardiac index was calculated as 1.43, and her EDP was around 40. This is the left coronary circulation. You can see she's got a very large circumflex with diffuse disease in the circumflex, as well as obtuse marginal, and a high-grade sequential calcific stenosis of the LAD as well. We advanced the catheter from a pigtail catheter from the right radial and took an image of the aorta just to see what MCS device would be available since she is in shock. And as you can see, she has no femoral access. So what we did is we then engaged the left subclavian to image it and ensure that it was patent in the event that the patient was a surgical candidate. She was seen by surgery, quickly refused due to her comorbidities and presenting illness. So what we opted to do then is obtain left radial access while maintaining our right radial access. We advanced a JR4 catheter and put an 018 wire, took an angiogram, highlighted the axillary anatomy. As you can see, here's the lateral thoracic, the subscapular circumflex vessels. We then obtained micropuncture access in the axillary artery under ultrasound and fluoroscopic guidance, as you can see highlighted here, and then used one perclose and then upsized the arteriotomy to a 14 French, and then went ahead and put our Impella device in through the left axillary artery. And then proceeded with our coronary intervention, beginning with the left coronary circulation. We went ahead and performed a DK crush of the circumflex, as you can see here, with a reasonable angiographic result. And we did do a CSI atherectomy of the LAD, given its calcified nature, after intravascular ultrasound assessment, and put one long stent. You can see with a reasonable result there. And then went ahead and finished up with a dry closure technique from the left radial artery, because the patient overall appeared relatively improved. Her hemodynamics remained stable. Her blood pressure was in the 120s. Cardiac output was stable in the 1.9 to 2 range. So we went ahead and inflated a balloon, which was 8 by 40, and then performed a perclose of the arteriotomy. and finished up with a DSA angiogram of the left axillary artery. As you can see here, with no extravasation, that was our point of access. And the patient did well and came back for a staged intervention to the right. The second case I'll present is a 76-year-old male with end-stage renal disease, was found to have severe multivessel coronary disease, severe aortic stenosis, mitral regurgitation with a reduced ejection fraction of 25%. He was seen at another institution when he initially presented and quickly refused for CABG, AVR, MVR, sent to us in borderline cardiogenic shock, placed on a dobutamine drip. Here are the images that were obtained from the outside institution. You can see there's diffuse disease, not only in the SFA, but all throughout the common femoral artery. And here are the baseline images, where again, you have calcific disease of the distal left main bifurcating into the LAD. And it's highlighted a little bit better here. There's you see the LAD better in this last view. And here's the right coronary with, again, a very heavily calcified stenosis in its proximal and mid portion. The baseline echocardiogram as performed here can show you there's a severely reduced ejection fraction. You can see there's a heavy degree of calcification around the aortic valve, as well as a large degree of mitral regurgitation. The CT angio was obtained quickly as the patient was being evaluated by surgery and consideration for a valve procedure as well. You can see there are diffuse rings of calcification all throughout the iliacs down to the femorals and basically throughout his body. You can see it was a very inhospitable groin. However, he did have stenoses at the ostium of the left subclavian on CTA as well, and then was found to have diffuse disease elsewhere. So we always typically use ultrasound. However, sometimes you don't need to. As you can see, it's very well illustrated. You can clearly see the vessel under fluoroscopy alone. So we were able to obtain micropuncture access, and then over an 014 wire in a 6-French catheter, we performed intravascular lithotripsy and basically performed sequential shockwave of the proximal femoral into the iliacs throughout with good overall expansion. And you can see it thereafter, our Impella CP sheath was readily able to be advanced with minimal resistance after performing sequential shockwave therapy. From there, we performed a single axis technique through that single sheath and did a balloon valvuloplasty with the Impella device in place through the single access point. Prior to proceeding with rotational atherectomy, there's our baseline angiogram. I'm sorry, these are overlapped. And we started with a 1.5 burr before upsizing the burr, as you can see, being sent into the left main into the LAD from there. That's the result after rotational atherectomy. And then we proceed with the DK crush of the LAD left main and circumflex vessels. We then also proceeded with a RCA rota and then high pressure balloon inflations. This was very, very calcified. It used a cutting balloon as well, and then deployed 2 stents in that area with a reasonable angiographic result. We then finished with what we call a hybrid closure, where we deployed 1 perclose and then basically closed after 1 perclose, downsized to a 6 French sheath, took an angiogram to ensure there was no trauma or dissection where we performed shockwave, and then finished with a Minx extravascular plug with no complications. The patient was then brought back 8 weeks later for a TAVR.
Hello? Are you done with your talk?
Yes.
Yeah, brilliant presentation. And as usual, it's a very complex situation, cardiogenic shock. You have to decide on which device and when, but very clearly depicted based on the various parameters that which device we can use in a given situation and can be successful. But how about your experience with VA ECMO? Just one question.
Sure. VA ECMO, we've had a very good experience with in the right patients. So all of these devices, it's important to recognize that they're not Lazarus devices in most instances. For patients that have presented with out-of-hospital cardiac arrest that have had reasonable downtimes or witnessed arrest, the outcomes are obviously better than patients with unknown downtimes and patients that are with several comorbidities. We have had a lot of success in patients that have had witnessed arrest out of hospital that are placed on VA ECMO initially, then weaned off by transitioning to ECPella to unload the LV, as we had kind of reviewed. The problem with VA ECMO is it's not an unloading state in the setting of cardiogenic shock. It's more of a hemodynamic complete support device. So we will use a combination of either ECMO and IABP, or most commonly ECMO and Impella, unload the left ventricle, then wean off the ECMO, and have had several success stories in that fashion.
Brilliant. Thank you very much. May I call upon the next speaker, Dr. Parvez Miraj. He will deliver a talk on PCI in calcified lesions, lithotripsy, rotablator or orbital atherectomy, and versus rotatripsy. When and why? The case-based learning.
Good evening to everybody in India and good morning to those in the US. Thank you very much for the opportunity to be here and give this great talk. And it's a tough act to follow, as Dr. Johar said earlier, but now I'm in the tail end, so I get to follow everybody. So my talk was pretty much on calcified coronary disease, and so I decided to make it a little bit of a broader topic in a case-based series as was requested. So you will see the first slide should be moving. Very good. So I decided to break it a little more case-based, and I think, any audience participation at the end, with questions, obviously you're more than welcome. But these are two different lesions, as you can see here. Lesion number one, you can see here on the right, you can see is clearly a very tortuous RCA. And what we're seeing in the tortuous RCA is a lot of calcium, as you can see angiographically. However, it is tortuous, which is a very important piece, I think, of the conversation. On the right, on the right side of the screen, you'll see here an LAD, which is a little more straight and clearly has a lot of calcium in the whole midsegment. But two different lesions, both calcified lesions, but obviously to be treated very differently. I'm going to review a little bit of the tried and true and tested orbital atherectomy and rotational atherectomy devices. In India, I don't know if you have orbital atherectomy available to you, but I know you have rotational atherectomy. So we'll just talk about both, and we'll go through and we'll work our way to lithotripsy. As you can see here, rotational atherectomy, as we all know, concentrically spins on a wire. It's different size burrs, starting at 1.25 millimeters all the way up to 2.5 millimeters. Most commonly used burr sizes are 1.25 and 1.5 millimeter burrs. Whereas the orbital atherectomy is a single crown. Most commonly, it originated in the peripheral vascular space, using an atherectomy in the legs, in large vessel SFAs, and also small vessels below the knee. However, it's moved to the coronary space and has a single burr size. However, it uses two different speeds, and because it's an oscillating device, not a rotational device, the faster it goes, the larger the arc it forms, and therefore the larger the cutting space. So you can use one device for more versatility. The rotowires is a rotofloppy and is a roto extra support. Just to review the wires, as we all know, orbital wire is very similar. They now have a floppier wire, which is called the flex tip advance, and they have the regular advance wire, which is the original stiff wire. Obviously, in more tortuous vessels, the stiffer the wire, the less benefit you'll have. We were fortunate enough to present our own outcomes looking at the comparison of these two groups of patients, both orbital and rotational atherectomy, and a propensity support adjusted analysis. And you can see here that among the patient's outcomes, there were fewer myocardial infarctions in the patients who underwent orbital atherectomy. In this particular cohort, there were no deaths, but I wouldn't take that as a no mortality signal. There can definitely be mortality in any atherectomy cohort or patient. And you can see here that if you break it down by all the multiple clinical trials that have been formed looking at a meta-analysis, you can see here that fluoroscopy time, contrast volume, coronary dissection, cardiac tamponade, in-hospital mortality, periprocedural MI, slow flow, no flow. For the majority of these cases, there is really no difference between the two groups. However, really only fluoroscopy time is more indicative and more towards the orbital atherectomy arm, and diffuse device and induced perforation favor the rotational atherectomy arm. However, this is, of course, very case specific. So looking at characteristics of the vessel, as you know, the larger the vessel, the more difficult it is to form effective or atherectomy, and therefore the larger the burr you need. The advantage of orbital atherectomy is that you can perform all this with a 6 French sheath, and you don't have to upsize. So as I know in India and as in the US, we're all radial enthusiasts, and so obviously if you want to try to go from the radial approach, this is a huge benefit to you. When you start getting to any rotational atherectomy burr greater than 1.75 millimeters, you need to go with larger guide sizes, 7 French and 8 French. Obviously doable from the radial approach, but not the most common and not the most easy for the patient. Vessel tortuosity, of course, mostly due to the wire biases. The new Viper wire that's for the orbital atherectomy is more floppy, therefore it's less likely to bias. However, still, with orbital atherectomy, you're more likely to have issues when you're traversing more. Concentric tight calcium is where rotational atherectomy is always been the king. It front cuts, and therefore it can obviously engage the lesion better. Osteal lesions as well. When you have an osteal RCA, an osteal left main lesion, due to the coaxiality, it is still better to go with rotational atherectomy. If you see here, this is an RCA lesion in a person that had multi-vessel, both left main and RCA disease. I'm only showing the RCA for the sake of the time of the presentation. An impella was actually placed here to support the patient. This was actually a patient that we did as our first patient. Dr. Johar and I did it together, actually. Our first patient when we moved over to the new hospital back in 2015. These are not the kind of cases they were doing, and so it was very together. This is a rotational atherectomy. Two burrs were used, and successful, as you can see, atherectomy. During the process of that case, the patient went non-pulsatile in their blood pressure. Therefore, the impella device was actually very appropriately used. My former fellow and colleagues, we published this in ACC in 2016. The use of pacemakers in RCAs, very tight RCAs, using atherectomy. Of course, that was traditionally always the case. We have since moved away from using pacemakers in general and do pharmacological management as much as possible. However, orbital atherectomy definitely decreases the likelihood of your need for pacemakers in the setting of heart block, because heart block doesn't usually occur for prolonged periods of time. The advantage of orbital atherectomy is that it's bidirectional, and you will probably very rarely, if ever, get a orbital atherectomy burr stuck. Whereas rotational atherectomy, if your technique is not accurate or not good, you have the potential of getting that burr stuck, and therefore technique is very important when using rotational atherectomy. The concentric versus orbital motion is really where the benefit is. Now, if you're looking at in-stent restenosis, which is very obviously a very problematic situation. In India, you have drug-eluting balloons. However, we in the United States do not have access to drug-eluting balloons. And so brachytherapy and other techniques are really the only mainstay of therapies for drug-eluting stent restenosis. However, many times there's calcium or there's mal-deployed stents, and unfortunately, up till now, really there was no option except to just atherectomize the stents and to redeploy new stents after atherectomizing stents, and hopefully the calcium that were laid behind it. Rotational atherectomy is still the ideal choice for this. However, there are cases where people have used orbital atherectomy. As a CTO operator, this is really a tried and true space in the subintimal space when using rotational atherectomy. When we have a very calcified chronic total occlusion, we are able to successfully wire across. The best thing to do is to get an effective result. Otherwise, your restenosis rates are quite high in these cases. Therefore, rotational atherectomy is really the ideal option. And orbital atherectomy, there's minimal experience and really not something that I would recommend. So in general, the two devices really have their benefits and have their disadvantages. I think the key is to know what device to use when and understand the lesion specificity. I would say rotational atherectomy probably has the most versatile use space. Therefore, I think for most people who have rotational atherectomy, access to it is probably the best option at the present time. There are some disadvantages due to burr sizes and obviously sheath sizes. However, that's really the only major negative. So look at these two vessels. This was a case where we performed rotational atherectomy successfully. We're able to stent it, and you can see here the final picture, maintaining all blank branches. You can see here the LAD. What we did here is that we used orbital atherectomy since it was a more straight approach, larger lumen size, and we were able to, without any pre-dilatation after the atherectomy, we were able to place a stent and get a very, very good result here. This was the another case as an example to show you what we did with the rotational atherectomy. You can see here there's more proximal to mid-RCA calcified disease, and with the use of atherectomy and stent placement, we were able to successfully open the vessel. So, and I mentioned a few minutes ago, up till now, we had really no options, and I think IV lithotripsy is really becoming a game changer. For those of you who have not used it yet, its mechanism of action is really a high-speed sonic pressure wave created safely inside a balloon, and this is the device itself. So you can see here the balloon, and there are these pressure waves that are created once the balloon is inflated, and that energy is emitted at a certain rate. This may be people may be familiar with this with renal calcification and renal stones, and it's a similar concept, obviously, with a different utilization. This is the system itself. It's an integrated balloon, as I said. The lithotripsy is really performed at 4 to 6 atmospheres. The balloon itself has a rated burst pressure of about 10 atmospheres. You can see here there are 2 emitters, and they pulse. And you can see here that you can set the pulse wave, and you would essentially hit the button, and the button will activate the balloon. You pulse it, and you're able to cause fractures or fissures in the calcium. It does not actually ablate the calcium. It does not remove the calcium, but it definitely causes just fissures so that the likelihood of a perforation is less, albeit not 0, and the likelihood of stent expansion or balloon expansion is significantly higher. This is a case example, as I'll show you here, is a left main and LAD. The left main is de novo calcium, and the LAD is actually instant restenosis with calcium behind the stent. So in the same patient, so you can see here what was done is that a balloon was used, sized appropriately for the left main. Lithotripsy was performed, and then the decision was made to do what to do with the LAD. And you can see here, after high pressure balloon inflations, there was still a waste, what we'd call a dog bone waste. And so what was done was the residual stenosis after traditional balloon angioplasty just wasn't appropriate. Therefore, what was done was we took a lithotripsy balloon, a 4mm lithotripsy balloon. It was placed in the area that was under deployed in the stented area. The pulsations were initiated. Final post dilatation was performed, and then obviously the left main was finalized. And you can see here a very good angiographic result with both the LAD and the left main. You can see here that a minimal residual stenosis you can see here at the final lumen diameter. So in conclusion, I'll just say that the use of rototripsy, as was asked in the title of the talk, is not something that we typically do very often. However, what we could say is that the closest thing I had to it was the instant restenosis using lithotripsy, and I think that's a very apropos conversation to have, is that, I think the imaging or the use of imaging for these calcified lesions is very important, because if you have suboptimal stent expansion prior and you place your stent and you're unable to expand your stent, at that point, the only thing you can do is either use high pressure balloons or use IV lithotripsy. The benefit of having imaging is that to be able to use the appropriate atherectomy device prior to your stent deployment, so you have more options available to you. This is still a relatively new area. The trial for coronary disease, the DISRUPT trial, is still ongoing in the United States. And so the data will be interesting to see how it shows. It's an imaging-based cohort. So stay tuned. Hopefully we'll be able to see what that data shows in the near future. Thank you very much.
Thank you very much for a brilliant presentation on IVL and rototripsy and rotaplator all together. Now we have several questions being asked, and start with the Navneet's case. Which coronary wire was used in Basilica technique? Navneet?
So the wire that was parked as a support wire in the left ventricle going through the guider was the V18 wire, just because it gives you support in the LV. For the snare to be held into the LVOT area. And the Asahi 20-gram tip wire was used to traverse the valve leaflets.
Second question also is there for you. So the second question. And the second question is, how do you decide when do you do a basilica and when do you do a chimney? So that was the question that was asked. I think you said it in your talk, but I think better you clarify it again, please.
So I think it will be wrong for any one of us to say that we are experts at any of these techniques, because
absolutely.
So far,
because very few, 1 to 4% of the patients will have this problem, basically of the low coronaries, of all the TAVR cases done.
So I think for those of us who have done all these TAVR cases, chimney technique has been the traditional way to do it, only because it was the only option available. Simple, straightforward, anyone can wire and stent coronary artery. Basilica is a newer technique, so I think we all need proctors and need more experience with it. The main disadvantage of the chimney technique, as we said before, is that it's very hard to re-engage the coronary arteries if there is restenosis or you need a repeat intervention on the coronary artery. And the long-term results may not be as favorable because there is stent deformation that may happen. And Basilica is probably the best and the most clean way to have a direct access to the coronary artery through the stent, through the valve leaflets. So I think moving forward, as the more dedicated catheters and equipment becomes available, I think we're going to probably shy away from doing chimney for any of the patients. I think Basilica may become the standard approach for most patients. So I think right now, if you don't know how to do Basilica, there's no proctor available, then chimney is the only option available. So, but if you can, I think Basilica should be definitely be considered for every case.
Third question is, how do you electrify the wire? RFA, is it?
Yeah, so there's like electrocautery, and we use like 50-watt power to do it. Okay. The main thing is that all the wires have insulation on it, so you have to scrape off the insulation to be able to electrify the wire.
Okay. Next question for Rajiv Johar. Rajiv, question is, when you have a thrombosis seen everywhere and D-dimer is high, what dose of low molecular weight heparin do you use in these patients?
So we are using, in the hospital, we're using full dose heparin, keeping a PTT of 50 to 70, closer towards 70. And we're using a full dose of enoxaparin.
Enoxaparin.
For full anticoagulation.
Okay. Because there was one recommendation from NIH, from UK, from Oxford University, that according to the weight and the level of the D-dimer, up to 1,000, 1,000 to 3,000, and more than 3,000, and the weight of the patient, all it taken into consideration. Accordingly, low molecular weight heparin doses are recommended, enoxaparin basically. But when you have more than 3,000, enoxaparin doesn't work there, and something else is being used in those cases.
There was a paper that was published yesterday or day before from Mount Sinai showing that patients who have COVID positive should all be on regular full dose anticoagulation, and their prognosis is better.
Yeah, your experiences with the heparin is better, is it?
We use heparin. We use mostly heparin.
Mostly heparin, okay. That's also one of the good options, I believe so. And then we have more questions coming. Lots of questions are there. What has been your, again, Dr. Rajiv Johar, what has been yours at the Northwell initial experience with use of interleukin-6 inhibitors in patients with fulminating myocarditis?
We haven't separated them out in terms of fulminant myocarditis, but the moderate to high risk patients who have got remdesivir, we don't have the data out yet because it's not been published, but our initial experience has been positive. I can't tell you the data. I don't know the numbers.
Okay.
But there are data around the country that have shown that IL-6 inhibitors have shown benefit in moderate to high risk patients.
Okay. Another question is, Dr. Rajiv Johar, again, what level of PP PPE gives 100% protection to the operator and the staff in the cath lab?
The obvious answer is you never get 100% protection.
Okay.
The reality is that, the patient should be masked. We are masked. We wear gowns, caps. Some of us, Dr. Miraj puts a hood on front of the mask.
Yes.
So, the reality is that you can never be 100%, but the more cautious you are, the less your risk.
Okay. The next question is for Dr. Raj Tayal. When do you use in a cardiogenic shock the combination of ECMO and Impella? Do you have any experience of the results when combination is used? Your sound, unmute, please.
Yes.
Yeah.
Hi. Yes, we do have a reasonable experience with it. Again, it's about appropriate patient selection. However, the best instances are when there are issues maintaining not only cardiac support, and perfusion and supporting the entire hemodynamic parameters. So when patients are presenting either with out-of-hospital arrest or in fulminant shock, and we're not able to fully support them with left-sided support alone, there's issues with oxygenation. Usually VA ECMO with a combination of Impella will help unload the LV, perfuse all the organ systems, and then also provides a great mechanism to wean patients off of ECMO and transition them only to a left-sided support system. So you're able to provide biventricular support, oxygenation support, and then gently wean them over a course of a couple of days to weeks.
Okay, thank you very much. Again, question for Dr. Rajiv Johar. Considering the PCR sensitivity of 60%, how do we go about other modalities for the diagnosis?
It's a big problem. We've had patients who've been negative twice, went for bypass surgery, and then after the surgery turned positive. So the reality is that, you have to look at the base theorem pretest probability of a patient being COVID positive and utilize that. It's like everything in life. You use all the data available to you. So one is the history, and then two is a test. The swab test is better. The serologies are the best. The new Abbott rapid test is not as good. It's about 70% specific.
Yes.
So again, you're never sure. You have to assume everyone is COVID positive. You need to protect yourself and the patient as much as you can. You have positivity that gives you that's good to know. If it's negative, does not mean the patient is definitely negative.
I think some people are still doing X-ray and CT scan as well, in addition to the PCR test. Are you doing that, Rajiv, at your center?
It's just very similar to the HIV era, right? When we would get X-rays and you'd say this is PCP pneumonia. I mean, we see that all the time now. So we do get X-ray on every patient, but the patients present with severe dyspnea. I mean, in general.
Yeah.
But remember, 80% of the patients are asymptomatic, and so the reality is that with all due respect, someone on this panel may have maybe COVID positive, may have had COVID. We don't know.
Yeah,
absolutely. The another question that comes to the mind, that when I read somewhere that if you do HRCT, as the point raised by Dr. Dagubati, that if you do HRCT and also the PCR and both are negative, then you are protected 95%. Yet 5% is still a possibility that patient may be having a COVID. So
you'll never be 100%.
Absolutely.
And you have to assume the patient has it. You may not, if you have very limited PPE where you have to choose, then that would play a very discerning factor.
Absolutely. I agree with you completely. And how do you find the rest of the drugs, the remdesivir, the chloroquine?
Hydroxychloroquine had initial luster that's sort of lost favor. Some people use prophylaxis 400 milligrams a week. Some people use it. Some people used it with Z-Pak or zithromycin. Honestly, it has lost favor in the United States. Very few people are using it now.
Okay. And there is another question that if you have a patient with high obesity and the COVID, what is the prognosis like for them if they are between the age of 45, 65?
If you look at the risk factors and the comorbidities, hypertension and obesity are the two that are portend the worst prognosis.
And another thing is the ECG changes precede or the echo changes precede the changes in the cardiac involvement?
The reality is that we never do an echo without an ECG. So we always do the ECG first.
You need to correlate well with it because it's not a type 1 MI, it's a type 2 MI, right, where demand has increased.
We're seeing, the classic diffuse ST elevation pericarditis, we're not seeing them as often. We're seeing very focal, inferior or anterior EKG changes that when you do an echo, the EF is normal or it's some mild regional wall motion abnormalities.
Okay. And there's another question for Dr. Parvez Miraj. That when do you decide that you will have an IVL on this patient and not the rotablator?
That's a good question. So objectively, we don't really have the answer to that question yet. Looking at the data from Europe, the initial data that I've seen, the imaging cohort that's not been published yet, there's some suggestion that less than a 270-degree arc of calcium on imaging, in those particular cases, IV lithotripsy may not be as beneficial as atherectomy. And so therefore, in my personal opinion, I still think that the evidence and the experience we have with rotational atherectomy is still so much greater than we have with IV lithotripsy. So I would still go with rotational atherectomy first. Okay. I think there are some subsets of cases, such as large vessels, maybe diffusely calcified large vessels, which may actually not be effectively atherectomized with rotational atherectomy. We don't know if IV lithotripsy would be more beneficial in those cases, but that would be the theory behind it. But in general, the folks in Europe and the folks who are performing the studies here in the United States have been suggesting that anything less than a 270-degree arc of calcium in your coronary artery doesn't really portend a better outcome for lithotripsy. After all, you have to understand that you need sort of a rigid pipe in order for the lithotripsy to work. And that rigid pipe only exists with at least 270 degrees of calcium. If you only have 90 degrees of calcium, the majority of the vibration or the majority of the lithotripsy will be absorbed into the softer tissue, and therefore it not be as effective.
Brilliant. I have one slide, and which I am going to share on the screen. Okay. Can you see the slide? Hello? Hello?
Yeah, yes, we can see it, yeah.
Yeah, it's a very interesting slide. It's only lately presented in JACC, Interventional Journal. And this study is from UK, Oxford University, by Adrian Banning and Maria Di Maria. Now, this study has suggested that if you have a high degree of calcium content on coronary angiogram, we have to take into consideration in this algorithm whether balloon crossability is there or not. If the balloon is crossable, then pre-dilate vascular imaging either with OCT or IVUS. If you find there is a calcium in the media, deep calcium, intima and media, deep calcium, then straight away consider lithoplasty. If you have only an intimal calcification with 180-degree arc, more than 5 millimeter length, and the thickness of 0.5 millimeter, then you consider rota or orbital atherectomy. And then if the optimal balloon expansion is there after the rota, then stenting we can consider and decide optimization based on the OCT, and either with the non-compliant balloon or with the OPN balloon, high pressure balloon, or you can use even in post-stent, you can use for the stent expansion, you can use lithoplasty. So this is a new thing that has come in my view, that you can use it even for optimization, the lithoplasty. Then if you have a patient which has a balloon where balloon is expandable, then you can consider a balloon, optimal balloon, then you can consider if one of the criteria for the arc of the calcium is less than 80 degree, less than 5 millimeter length and 0.5 millimeter of calcium thickness, and you don't have this criteria, then no rota, straight non-compliant balloon or cutting balloon or scoring balloon. If it expands, yes, then stent. If it doesn't expand, then consider lithoplasty again. On the other side, if the lesion is not balloon crossable, then crossing with the macrocatheter, if possible, cross with the wire and do rotablator. But sometimes even wire, if the macrocatheter is uncrossable, then direct wiring if not possible, then laser is another option, and then optimal balloon expansion and stent and angioplasty. If the balloon expansion is not optimal, then lithoplasty, of course, again, and then go ahead and do stenting and stent optimization with OCT. And if not completely expanded, then you can use non-compliant balloon or super high pressure balloon or lithoplasty balloon. So lithoplasty means for a deep calcium, yes. Then unexpanded balloon after the rotablator, yes, second indication. Third indication is if after the laser or for rotablator, if balloon is not expanding, then again lithoplasty you can consider, and lithoplasty even for stent optimization. So these are the 4 indications for the lithoplasty, which I came across just 1 hour before we started the program. So I thought I will just discuss this so that audience is enlightened. This is from UK.
And that's a very good slide. Yeah.
I agree.
Yeah, so it's a very clear algorithm that we have to adopt, and not all patients are for IVL and not all patients are actually for the rotablator. And when to use a combination is also very clearly depicted in that algorithm. And I think
this webinar you set up is so useful, because we need to get away from and get past the COVID, and we need to go back to putting MCS with Tyel's patients and doing, TAVRs, and I don't know about the AR stuff. I'm still hesitant to do that, but but if in Virginia, it doesn't really matter. And then and Pervez with his calcium. So I think it was very, very important to get this out
absolutely
there.
Absolutely. The only positive side, something positive side of the COVID is this webinar teaching, education and learning.
From your own bedroom. I love it.
That's true.
Yeah, that's really, really something which is positive takeaway from this entire thing. And another question for the other panelist, that suppose you have a very tortuous, Dr. Miraj, if somebody has asked this question, if you have a very tortuous coronary artery and heavily calcified, then what is your strategy to do a rota? What kind of rota size, burr size will you employ, and what speed will you consider? All those things. May I have your?
It's a good question. I think this is an experience question more than it is a data question. The experience would suggest that you should use a more floppy wire to avoid wire bias in the vessel. The second point would also be is that you should still stick to the 0.6 rule, the 0.6 vessel size rule that we would have typically for rotational atherectomy. So if you have a 3 millimeter vessel, you want to try to do 60% of the vessel size. So that'd probably be ideally a 175, no larger than 175 burr, probably 1.5 or 175 burr. You don't want to go too small with the burr. The smaller you go with the burr, the more likely it is to watermelon seed or to go past a bend or a calcific bend and then get stuck. So the mistake people make is sometimes using a small burr and actually trying to think that that would be safer in these tortuous vessels. It's actually quite the opposite. You don't want to oversize your burr, but you want an appropriate sized burr. The last thing is that your technique is probably the most important in these tortuous vessels. So the speed, rotational speed, is more dependent on what you're comfortable with. No one should really be under 160,000 RPM for the rotational burr speed. You probably shouldn't be over 180,000 RPM either. There are times in which you will go higher, but that's very rare. You'll activate too many platelets and you'll cause too much thrombosis and no reflow. So ideally, you want to try to keep it slow at about 160, maybe maximum 170,000 RPM. But it's that short, slow pecking motion, not driving the burr into the calcium and avoiding it getting stuck. I think that's probably the most important piece of it, which no lecture could ever teach. That you have to get your hands on the device and actually do it with your own two hands and do it that way. But I think that's probably the best way to describe it. There is no science. It's a lot of art.
I think Ramesh has some point to make. Yes, Ramesh?
No, Rajiv, it was.
Rajiv, sorry.
Yeah.
Raise, what's important though is the speed. I agree with this, the slow speed, but you need to understand the decelerations and to make sure that they're able to accelerate. The tech or whoever's manning the rotablator needs to increase the speed to the speed you set it at. Because once you decelerate, the chance of having a complication is much, much higher.
Okay, and you're right, Parvez, that we don't have orbital atherectomy in India at the moment. But what is your experience with our orbital atherectomy given this case example that we discussed about the rota, tortuous with a lot of heavy calcium?
Right,
is
so
there
I think
any
it's a good
preference?
There was always the preference toward rotational atherectomy until recently. Okay. And then when they released their new Viper Wire Advance, which is the floppier wire, similar to the rotational floppy wire, it took away a lot of the wire bias. The reason why we shied away from orbital atherectomy in very tortuous vessels was because of the extreme wire bias and the higher risk of perforating the vessel, because your crown would be orbiting against the vessel and potentially perforate. So now with the more floppy wire, that's less of an issue. It's less of a concern. So I don't know if that advantage is one versus the other. Again, this is a personal preference. Experience-wise, I still have more experience doing very tortuous vessels with rotational atherectomy, so it's probably what I would turn to. However, that doesn't mean that orbital atherectomy is bad in those cases now with the proper wire.
Yeah, I think any other point that any panelist would like to point out from crosstalks, from anybody's talk, if you want to just make a teaching point or learning point, it will be worth the while.
Yeah, I think one thing I would talk about with Parvez's talk is that, we've been trained, at least in the US, that with orbital atherectomy, you never want to go do osteal lesions. But you have an opportunity, if the vessel is very large, to go distal and on the way back, the retro side, the back end of the...
the advantage with the orbital atherectomy is both sides it can cut.
Right. And so that is an option that is available to us.
That's a good idea. Good point. Ramesh, anything that you would like to mention?
I think it's a very good webinar, excellent talks by all the speakers. I really enjoyed being here. And outside it is snowing for us again. And I can't believe that in May we have a snowfall here in West Virginia.
Ramesh, you left New York for Virginia. It's your fault.
Yes, I agree. But there is a lot of importance that is being given for COVID in India right now. You're peaking. You will be having probably the peak in 6 weeks from the time it has started in India. All of us have to be very careful, as Dr. Jauhar mentioned. proper PPE is important. There is no magic pill. There is no 100% safety for anybody. You can do whatever test you want to prove it in a patient, but as he mentioned, there could be asymptomatic carriers, so you have to be careful not to expose yourself. I know every town in India now is opening up all the wine shops. People are exposing themselves to all these liquor stores and now they'll come back to your home and start working as maid or something, and then you're a car driver and you're exposing yourself. So be careful, and we all have to be cautious during this season, but not forget our basic science and basics of cardiology, how to tackle complex lesions, when to use mechanical circulatory support properly. I know in India now you have IVL as well as Impeller. Even though both of them are expensive, but still some people are getting experience in that, and I think it is important to know when to use them and follow a good algorithm, as was shown by Dr. Bang, and to make sure that which lesion should be treated appropriately with what type of device. There is no single magic pill. And as for Think Tower, definitely Basilica and Chimney. Basilica is something that even I have not done, so you have to make sure that if I have a case, I have to get a proctor, and we need to make sure that we are doing the best for the patients and to avoid any complications. And I think one question somebody asked me is about how to can we oversize the balloon expandable valves to treat aortic regurgitation? That's where I thought I could do it. And I had a valve embolization because there is no accurate sizing in these large annuli with, 29 is the maximum balloon expandable valve that we have in the United States. And if it is a larger annulus and there's a risk of embolization, and you have to make sure that the surgeon is in the room ready to open up the chest if there's a bailout. So one of the things in our checklist is actually the timeout. During timeout, we also make sure that is the patient a bailout candidate or not, so as to make sure that the perfusionist is in the room, the heart-lung bypass is primed in such complex cases where large annuli, and we're trying to expand the balloon, oversize the balloon expandable valve.
Anybody else, Raj Thayal, Dr. Raj Thayal, any point that you would like to make which is not covered in entire crosstalks? Any point that you would like to say that this is, even considering COVID, because you have huge experience with the COVID in Newark and Newark, New Jersey, both places. I think you may be able to enlighten more people in this fight with the COVID.
Yeah, this has truly been unprecedented, I think, in a number of ways, both in the way that patients are presenting, not only with cardiac, but non-cardiac manifestations, being coagulopathic, being hypercoagulable, everyone having some form of troponemia, presenting with heart failure, acute, chronic. We've seen a wide variety of things. We've used MCS somewhat sparingly in these patients, because a lot of them we've seen have had very protracted but not very positive outcomes. But we've learned from our experience and have gotten stronger. I think, as Dr. Nahar had highlighted, I think it's formed a lot of strong inter-community and intra-hospital bonds, and we've really seen some great success stories. I think this has been a wonderful kind of conference or opportunity to talk about COVID and non-COVID topics. All of them are very, very relevant, but I think everything was highlighted both from a structural heart perspective as well as MCS and complex PCI, so it was very well put together and very enjoyable.
Good, thank you very much. I think excellent talks delivered by all the speakers, and all of you are absolutely brilliant in your experience with the COVID. And we have a point, I have some point to make here, that in India, we do only PCR. At the moment, we don't have antibody test available in India. Okay, so PCR sensitivity is average sensitivity of PCR in all three stages of the COVID infection. First is the nasopharyngeal phase, second is a lung phase, and third is a multi-organ phase. So in all these three phases, we have seen that sensitivity is average sensitivity is about 50–60% of the PCR. So a large number of patients may be having PCR, may be having COVID, but PCR is negative. The positivity rate of the PCR in India is 4%. We have done by now, I think, about 10 lakh tests. And it's most of the time it is about 4%, 3.8 to 4%. Whereas in America, more than 35 lakhs test has been done. The test is positive up to 20%. And in Europe or whole of UK and other places, it's about 15%. So perhaps we may be having a greater immunity because of the demographic, more younger people. Average age in India is 28, only 28 average age in India. And older people are only 7.5% above the age of 65, above the age of 75, only 2%. And those are all protected at home. The children don't allow them to go out. So basically we are able to see large number of patients though, but we are not so far, except in Bombay and bigger metros. In other places, we have not crossed the borders of what you call a community spread. It looks like many districts in India, about 300 districts in India, are totally COVID-free, where interior part of the India and where the normal activity, economic activity is already partially going on. And although there is no travel going on, the air travel, no rail travel, so travel is practically not there. Only non-COVID cities where no COVID is there, they can go cross-border by road. So it's a kind of situation we are in, the whole world is in. It's quite a, but do you think how long will it go on in America? That's a very important, relevant point I want to ask, that when do you think it is, how long will it go on? It's May now. So how long do you think it may go on?
So we're going to resume our cardiac elective procedures in 3 phases. And, it depends on whether you talk to people that are in the business perspective, the medical perspective. Everyone has been all over the map with regards to what their estimates are. I think realistically, we don't expect to be at 100% until early to mid-June. I think this persists in our area, at least until mid-June to early July. And I think the impacts and the way that it's affected the way that we deliver care will remain forever. We've segmented the hospital in the way that we provide care and closed it off. So we're all covering units and pods. All of our cardiologists and my colleagues have been functioning as hospitalists and intensivists and covering particular units. And so I think we'll see large impacts on not only what happens now in the short term, but in the long term as well.
There's a question.
Dr. Bang, to your question, I think you specifically asking if anyone can predict how long this will last for. I don't think anyone can, but I think we have an experiment happening before our eyes. There are some U.S. states that are opening, like as of now. Upstate New York is going to open. New York State is opening in phases. Upstate New York is going to open. City is staying closed though. So I think in 2 or 3 weeks, the experiment that's happening about how to open and how widely to open the businesses, you're going to see if there is a spike in those on those places where they become new hotspots, and that will probably impact our overall projection as to what's going to happen to the rest of the country or the world. I think there's lesson to be learned in the next couple of weeks from all these places that are opening now.
There's the one last question coming up for Dr. Daggubati. Is there a role of oversizing balloon expandable platforms to mitigate the risk of valve migration?
No, that's a one, I was saying that I don't think we can really mitigate the risk. They already oversizing balloons. However you try to do it, there is a risk of embolization. And I have seen that people have done up to 800 or so square millimeter annular area were treated with a 29 sapien. But there is always a risk. We tried with the Evolute Evolute Pro Plus to an area of about 770. That valve actually embolized as well, aortic, and so you have to be careful. There's always a risk, and immediately trying to put a second valve is the best one. That's how we treated that patient with a second Evolute, trying to keep it in. So it's almost like a two valve in valve, so that immediately we were able to save that patient. But unfortunately, with the balloon expandable, if it is embolizes, that is going to be much more higher chance, which we had. One patient had an embolization into the ventricle, and but he was stable, so we had time to retrieve it by open AVR and taking the valve out and putting another suture. So in short, I don't think you can completely mitigate the risk of valve embolization by oversizing.
Okay, how do you, there's another question of any one of you can answer. How do you distinguish between myocarditis and type 1 myocardial infarction in patient with regional ST elevation?
Avneet can take it, or Raj?
Raj, can you answer this, Raj?
Avneet is there, yeah?
Avneet is there. Avneet can answer it.
In short, I don't think you can. If you have like motion abnormality,
exactly.
In this,
exactly.
If that localized on the EKG, I don't.
Absolutely.
The only way it's going to be doing a
absolutely, because TROPA is elevated in all the patients. So TROPA doesn't help you in any way. None of those infarction markers can help you in doing that. But I read somewhere that myoglobin is something which is there as a marker for detection, whether this is myocarditis or ischemic infarct. Between the two, I think myoglobin remains elevated only specifically to the infarct as a marker, which I saw in various kind of presentation, but I'm not very sure about what is the percentage of it being positive and the overall, the clinical value of if it is positive, how specific it is.
I think the only way you could be certain is either do cath them or do a cardiac MRI.
Absolutely, absolutely. I think we had a brilliant session, and we can have it another session sometime later after a month or so with all of us together again and do some different topics. How do you like this idea?
Sounds great.
It sounds great. So people, come to know that you are coming again. So that's a great thing. Everybody, many comments are there. People have appreciated the talks that you delivered, and they have learned a lot. They are saying that also in the chats that they have learned a lot. There are about 50 chats. They are there, and they are all praising you. So it's good. All in all, wonderful having you guys, and have delivered very specific talks in this COVID era, and grateful to you. Thank you very much. And that's all. We can only clap at the moment for all of you guys. Thank you.
Thank you so much, very much. Thank you. Everyone stay safe.
Yeah, hope so. Everyone stays safe. That's a good statement at the end.
Thank you.
Take care. Bye.
Bye.